versus the dual antiplatelet therapy in acute coronary syndrome patients and beyond. So in acute coronary syndrome, the standard therapy is dual antiplatelet therapy for 12 months, but one size does not fit all. And the clinical success is in balancing the ischemic versus the bleeding risk. Finding the sweet spot for each patient is not easy, but is it impossible? With a little bit of understanding, we can definitely do it to the benefit of our patients. And this talk is going to throw a little more light and clarification on gray territories. Aim of a dual antiplatelet therapy in acute coronary syndrome. In the first few weeks after PCI, the dual antiplatelet therapy is to prevent stent thrombosis. That is the first and foremost prevention aspect in the minds of an intervention cardiologist, the stent protective effect. But subsequently, the long-term goal is to prevent the ischemic events, that is the patient protective effect. So why are we using DAPT post-acute coronary syndrome? Is it only to prevent stent thrombosis? Stent thrombosis is prevented by a combination of thienopyridine and aspirin, but not by aspirin and or warfarin. Historically, this is how PTCA was started, initially with aspirin and heparin, and subsequently with aspirin and warfarin combination. Then there came the ticlopidine with its neutropenia side effects, clopidogrel being improvised version of the thienopyridine and safer version came in. We do have some amount of clopidogrel resistance, and to offset this, we have the more potent agents, namely the ticagrelor and prasugrel, which are currently recommended in acute coronary syndrome. Whereas in chronic coronary syndromes, we can use clopidogrel or aspirin. So we will see how to balance the choice between these drugs and where to use which one. And does clopidogrel still have a role in acute coronary syndrome? All these gray areas I hope to cover in the next 15 or 20 minutes. Now it is about patients and not stents beyond the 1 month or 2 months of therapy. Subsequently, it is to prevent cardiovascular events. And we all know that the cardiovascular events are highest in the first 1 year post-MI. If you look at the CV events during the first 365 days after an acute coronary syndrome, it keeps increasing over time over the next 1 year. And the CV events by between 1 and 4.5 years also continue to occur at a higher level. So the road towards cardiovascular disease is built by high cholesterol. So it is not sufficient to look and target at the antiplatelet therapies. We certainly need to aggressively handle the high cholesterol levels. And WHO estimates that blood cholesterol contributes to approximately 56% of cardiovascular diseases worldwide. And the more recent cardiovascular disease epidemiological studies in India, the great registry, higher rates of STEMI in India, worldwide non-STEMI is to the tune of 60% and STEMI is around 40%. But reverse is happening in India. STEMI is still very high, 60%. And we all know that STEMI carries a very high immediate risk and high immediate mortality. ICMR Urban Rural Survey increased prevalence of CHD. The Jaipur Heart Watch linear increase in CVD risk factors have been noted over time. The PURE study, the CVD event rate is in predominantly Indian population as compared to high income countries. The Mumbai cohort study, inverse association of CVD mortality and education in men. So the lower the socioeconomic strata and educational level, higher was the CVD mortality. The pro-life, 40% of deaths are attributable to cardiovascular diseases in India. And the ICMR India regional variations in prevalence of CVD risk factors, which are very high in pockets of southern part of India, in Punjab, where very high level prevalence is there, whereas certain other areas like Assam, Nagpur, Nagaland, much lower levels. Goals of dual antiplatelet therapy is to prevent new ischemic events to prevent stent thrombosis over time. As the time goes by, preventing stent thrombosis becomes less important, and preventing new ischemic events takes greater importance. And the coronary indications for DAPT are acute coronary syndrome. Whether it is managed invasively or medically, you need DAPT for the next 12 months in a standard format. Recent stent placement, whether it is for stable ischemic disease or ACS, the recommendation in chronic CAD is for 6 months and in ACS is for 12 months. Chronic ischemic disease, you could consider DAPT when there is a high vascular burden. And let's look at the indications. And when you look at the patients at risk of atherothrombosis, you have a continuum of risk, starting with people at risk with 3 or more risk factors. Then comes the asymptomatic PAD. That's why looking at the ABI could be one of the early markers of a significant atherosclerotic disease. Diabetes is a cardiovascular equivalent. Then here comes stable angina, symptomatic peripheral arterial disease, MI, stroke, TIA. Polyvascular disease comes towards the heart, and presence of stents, unstable angina, STEMI, acute stroke, and acute STEMI are all on the top of the list. Antiplatelet therapies play a pivotal role in acute coronary syndrome. Antiplatelet therapy has remained the cornerstone of treatment for patients with ACS because the plaque rupture or erosion is the culprit in leading on to arterial thrombosis leading to ACS. So it is not sufficient to give anticoagulant. You need antiplatelet therapy because these platelet activation is what predisposes to arterial thrombosis. 12 antiplatelet therapy with a combination of aspirin and either P2Y12 receptor inhibitors should be the treatment of choice in patients with acute coronary syndrome. So you have the strategy of DAPT with aspirin. Aspirin is the standard. Then you combine it with either clopidogrel in stable CAD. In ACS, also you could give clopidogrel with aspirin, in especially high bleeding risk patients, active bleeding, and severe hepatic failure, where you would not want to give very potent agents. Prasugrel is given only in patients who are subjected to stenting in an ACS scenario. It is not used in a chronic stable angina scenario, even if the patient undergoes a PCI, or it is not used for medical management of ACS. Ticagrelor can be used in ACS or stable CAD after MI. It can be used in patients medically managed with ACS or post-intervention. It is also used in patients with a high risk of stent thrombosis, like multiple stents or critical left main stenting or bifurcation stenting. So the potential benefits of DAPT with aspirin and clopidogrel alone. Stable CAD, if you consider the conservative management, if there is no history of MI, PCI or CABG, then you do not recommend a DAPT. But if the patient has had a recent MI and high CV risk, you may use class 2B, 12 months may be considered of patients with ticagrelor with aspirin. And patients with class 2, 12 months may be considered for clopidogrel. If you put a BMS, class 1 indication is minimum 1 month of clopidogrel therapy. If a patient is not at high bleeding risk, you could continue up to 3 months. If you have put a DES, it's recommended to go for minimum of 6 months of clopidogrel. And no bleeding risk and no active bleeding on DAPT greater than 6 months. High bleeding risk or significant over bleeding, you can shorten the DAPT up to after 3 to 6 months. You can shorten the DAPT. For patients with ACS, that is non-STEMI or STEMI, conservative management, minimum 12 months of ticagrelor or clopidogrel along with aspirin. CABG, class 1 P2Y12 inhibitor of CABG for 12 months, ticagrelor or clopidogrel. For PCI, BMS or DES, minimum 12 months, ticagrelor or prasugrel are preferred over clopidogrel in an ACS scenario. High bleeding risk or active bleeding, you can shorten it as short as 3 to 6 months of DAPT. No bleeding risk, you can consider longer duration. So the guideline recommendation is of antiplatelet therapy is for all patients without contraindication at an initial loading dose of 300 milligram and at a maintenance dose of 75 to 100 milligram for longer term treatment. There are two things which I would like to emphasize at this point. The loading dose of aspirin is always 300 milligram, preferably, and the maintenance dose should not exceed 75 to 100 milligram. There is no need to give a higher dose like 150 milligram, which gives no benefit but maybe increase instance of bleeding. A P2Y12 inhibitor is recommended in addition to aspirin and maintained over 12 months unless there are contraindications or an excessive risk of bleeding in an ACS scenario. That's a class 1 indication. So coming to looking at some of the trial data, effect of clopidogrel in addition to aspirin in patients with acute coronary syndromes without segment elevation, when there was a combination of clopidogrel with aspirin as compared to only aspirin, there was a significant reduction in primary endpoint, 20% relative risk reduction, and pre-treatment with clopidogrel with aspirin resulted in a 30% relative risk reduction in CV death, MI, and target vessel revascularization in 30 days post-PCI. The charisma trial patients with documented prior MI, ischemic stroke, or symptomatic peripheral arterial disease benefited from dual antiplatelet therapy with clopidogrel plus aspirin, superior to the single antiplatelet agent. And in secondary prevention, patients at risk for ischemic events, the CAPT trial showed clopidogrel was superior to aspirin, marginally with a greater risk reduction. Clopidogrel evidence in secondary prevention, clopidogrel optimal dose usage to reduce recurrent events in the ACS 7 trial, which was done in ACS patients. So this is again something which we need to emphasize. The clopidogrel loading dose in an acute coronary syndrome should be 600 milligram and not 300 milligram. That is 8 tablets of clopidogrel, 75 milligram was superior. And if you deploy clopidogrel for patients with ACS, it is better to give a double dose for at least 1 week, 75 milligram twice daily, compared to that of a single dose, which kind of counters the clopidogrel resistance whenever you use clopidogrel in ACS patients. The benefits of clopidogrel therapy early and long term. Clopidogrel aspirin was superior in terms of MI, stroke, and CV death at 31 days to 1 year. Addition of clopidogrel to aspirin in 45,000 patients with acute MI, randomized placebo-controlled trial. It was shown that 6 months versus 12 months, the SMART Day trial showed a superior outcome with a longer duration of function therapy of DAPT in terms of ischemic risk reduction. And whenever you combine statin with aspirin with clopidogrel, as shown in the gray study, compared to aspirin alone or aspirin plus clopidogrel, aspirin plus statin, the best combination following an ACS was an aspirin clopidogrel with statin. So DAPT with a high intensity statin should be maintained for the maximal benefit. Lowest mortality rate was in the combination therapy with statin, aspirin, and clopidogrel, looking at 15,693 patients at 6 months. In stroke patients, I don't think I need to talk too much about stroke because my next speaker is an eminent neurologist and he will take on more about this. I'll just make a brief mention. Lower risk of stroke recurrence and after minor ischemic stroke and TAE was noted. And dual antiplatelet therapy before coronary artery bypass surgery in patients with myocardial infarction. A prospective cohort study showed DAPT plays a key role in preventing ischemic events in ACS patients. 6 months post follow-up showed that DAPT before CABG in patients with MI has no effect on post-operative outcome compared to aspirin monotherapy. There was reduced rates of stent thrombosis and MI after 1 year of DAPT in this trial on extended DAPT. So how long do you keep a patient on DAPT? So the thrombotic risk is maximally reduced by DAPT therapy early on, and optimal duration is at least 12 months in a patient post ACS. So the optimal duration after ACS, whether it is stenting or not, is 12 months. After stenting in a non-ACS scenario is 6 months. So the seesaw is shorter duration, should be preferred in patients with advanced age, renal dysfunction, prior bleed, any previous hemorrhage, frailty. You consider a shorter duration to prevent the bleeding complications. And remember, the bleeding complications have a higher mortality than ischemic events. So a bleeding score risk is much higher on the rank card rather than even the ischemic risk. So a person with a very high bleeding risk should be more cautiously treated with a shorter duration of DAPT. Longer duration is recommended whenever there was a procedural complexity during PCI, use of multiple stents by areas like left main or an osteal LAD, patient factors like recurrent ACS, patient has PAD and CAD outside of stented segment, multivessel disease, and advanced atherosclerosis. So a guided P2Y12 inhibitor therapy after PCI. So standard of care is, you know that it is 12 months of DAPT for ACS, prasugrel or after PCI or ACS, and clopidogrel after elective PCI for chronic coronary syndrome. So guided escalation of dual antiplatelet therapy. You can switch to potent P2Y12 inhibitors or ticagrelor when the ischemic risk is high in patients even with chronic coronary syndrome. Prasugrel or ticagrelor, if there is a very high bleeding risk, then you could guided escalation, switch from moderate P2Y12 inhibition to clopidogrel. The maximal stent thrombosis occurs within the first 1 month. So switching to a moderate P2Y12 inhibition after 1 month is does not result in too much of problems in terms of advanced worse. And you could do a genetic typing to make sure that the patient does not have a clopidogrel resistance, which occurs in about 30% of patients. And if your patient is not having clopidogrel resistance, it's quite safe to de-escalate the therapy. So how long should DAPT be continued? Should it be continued for 3, 6, 12, 24, or 30 months? The currently available evidence speaks for individualizing the duration of DAPT. So you have multiple trials over the last 10 years on both the short and extended DAPT. So you need to take a call balancing the patient's risk for ischemic and hemorrhagic events into the account. A call for individualized medicine is definitely there. So where is the sweet spot between ischemia and bleeding? Short DAPT lowers the bleeding risk, but the ischemic risk is increased. Long DAPT lowers the thrombosis ischemic risk, but the bleeding risk is higher. So where do you find the sweet spot? So somebody who has a high risk of ischemic events and a low bleeding risk probably needs to be, can be given an extended DAPT. Somebody with a high risk of bleeding events, you need to give a shorter duration of DAPT, and somebody with both high risk of ischemic events and high risk of bleeding events, probably a standard duration of therapy. So these are some of the trials on extended DAPT. The DAPT trial, which showed that clopidogrel beyond 12 months prevented ischemic events in combination with aspirin. And Pexistimine 54 trial showed ticagrelor beyond 12 months at a reduced dose of 60 milligram BID compared to the 90 milligram BID for the first 12 months up to 33 months lowers the ischemic events with a slightly increased bleeding events. High bleeding risk versus high ischemic patient. Former is a more powerful influencer. So somebody who has had a high bleeding risk, then you need to favor more a shorter duration. When somebody has a low bleeding risk and high ischemic patient, then an extended DAPT can be considered. This is a host exam trial. So when somebody has taken the 12 months or 18 months of extended DAPT, beyond that, which is the best drug to follow through, whether you have to give a clopidogrel monotherapy or aspirin monotherapy for these patients, studied in a recent trial called the Host Exam trial, which is a very elegant trial of more than 5,000 patients, comparing monotherapy to aspirin for chronic maintenance therapy patients of CAD post-PCI. And the composite outcome of all-cause death, MI, stroke, and urgent ACS greater than BAPT bleeding was 5.7% in the clopidogrel monotherapy arm compared to 7.7%. Post 1 year, if bleeding risk increases with DAPT, what do? A paradigm shift in antiplatelet. Early shift from DAPT to clopidogrel monotherapy has shown not only reduction in bleeding episode, but reduction in events also. Stopping aspirin after 1 month reduces the risk of adverse events by 38%. Let's look at a case example of a high bleeding risk patient. A 66-year-old female, hypertensive, 20-year duration, diabetes of new onset, dyslipidemia, ACS, LBB, and trope was low positive. She came with pulmonary edema, and this is her we'll go to this case. That was a different case. A 55-year-old female with pulmonary edema, history of diabetes mellitus, 20 years. And she has had a CVA left hemiparesis from which she had recovered 3 months back. And an angio done at that time showed a double vessel disease of an osteal LAD disease with a totally occluded left circumflex osteal disease. She had anemia of 10.9 grams per DL, HbA1c of 7.9. She had EF of 40%. She was in pulmonary edema and hypotension, cardiogenic shock. So this patient was taken up for an emergency angiogram with a cardiovascular circulatory support in the form of an intra-aortic balloon pump was placed first. And this is her angiogram, which shows a non-dominant RCA, dominant circ, which was occluded completely and which was filling from collaterals from the right side injection. And she had an osteal LAD and a distal L critical 90% lesion. So this patient was taken up for an angioplasty of left main to LAD. And she was pre-dilated and then stented optimally with a 3.5 into 28 drug-eluting stent. So she was known to be a high risk. She was also of low body weight. Since we have stented the left main and the L6 was already closed, put her on, and she was started on ticagrelor plus aspirin. And to optimize the result, whenever you have have a high risk patient in a critical coronary disease, it's always better to optimize the result with imaging. And this was done with an imaging, the intravascular ultrasound, and the intravascular ultrasound showed an optimally deployed stent. Anything in the area above 8 millimeters good in the left main, and current recommendation is more than 10, and we got an area of 11.2 millimeters square, which means we had an excellent result of the left main expansion of the stent. But unfortunately, post-procedure, this patient developed a large hemorrhagic infarct and a left side hemiplegia, the same territory which a CVA 3 months earlier. So in discussion with the neurologist said we could conservatively manage her hemorrhagic infarct. She did not need an immediate craniotomy. So she was continued on aspirin, and ticagrelor was stopped immediately. The plan was to start clopidogrel, And after 2 weeks, a de-escalation strategy to aspirin was started. She recovered from her hemiplegia, partly to 4 by 5 power in the lower limb and 3 by 5 power in the upper limb. And she went home walking. She was continued on clopidogrel and aspirin, and imaging gave us the confidence to put her only on aspirin for a short period of time, and she was continued on clopidogrel and aspirin subsequently, and she's doing well. So bleeding is higher in women, and antithrombotic and antiplatelet agents are central to treatment of AMA in women also, but they also pose a higher risk of bleeding. The data from 24,000 patients of GRACE indicated that women versus men had a 43% increased risk of bleeding during hospitalization. And the risk is especially even higher in the setting of STEMI. So coming to the antiplatelet therapy strategies in women, there's no statistically significant heterogeneity when the effect of clopidogrel was compared between the sexes. On higher potency P2Y12 inhibitors such as prasugrel and ticagrelor also, no significant interaction with sex was observed in studies of the effect of each drugs on measles. But only a recommendation is when you use prasugrel in a patient, frail women, it is better to avoid prasugrel or use it at a lower dose like 5 milligram. This is another case scenario, 59-year-old man, coronary artery disease, hypertension and hyperlipidemia, sudden onset headache, mild dysmetria and severe nausea. On admission to the intensive care unit, CT scan demonstrated large hemorrhage with partial displacement of the fourth ventricle. So after consultation with the neurologist, a repeat CT was performed, and patient was put only on aspirin and withheld on clopidogrel. And the scan demonstrated no enlargement of the ICH or ventricular dilatation. And once that was confirmed, he was restarted on aspirin with clopidogrel, so as to prevent stent thrombosis as he had a recent PCI. So action on bleeding, if it is trivial, you can continue DAPT. If it is shorten DAPT or de-escalate, if you're on a potent agent such as prasugrel or ticagrelor, switch to clopidogrel. Moderate, switch to DAPT or shorten or de-escalate. Severe, you can switch to SAPT, or you may have to stop antiplatelet therapy for a short duration. You can de-escalate or shorten DAPT. Life-threatening, always stop APT, antiplatelet therapy, and re-evaluate once the acute scenario is recovered. So strategies to reduce the bleeding risk. If it's an acute coronary syndrome during PCI, you opt for a radial PCI, you do only the target vessels and use imaging guidance so that if you have to shorten the DAPT, you're safer. High bleeding risk scores need to be employed and clinical parameters need to be considered. Bleeding occurs, DAPT duration and DAPT intensity, and use of PPI to prevent GI bleed care should be used. If there is no bleeding, continue DAPT in the same protocol. If there is a bleeding, consider shortening DAPT, de-escalation or monotherapy. That is, stop aspirin and continue only with the P2Y12. The safest option will be a clopidogrel. So the clinical criteria of a high bleeding risk are kidney or liver disease, active cancer, anemia, low platelet count, previous stroke, recent trauma or surgery, use of oral anticoagulants or NSAIDs. So whenever there is a patient is on oral anticoagulants, like for atrial fibrillation or a mechanical valve, it is recommended that triple agent is used for the shortest duration in a stable scenario for 1 week, or in an ACS up to 1 month of triple therapy, following which you switch to pathway, that is oral anticoagulant with a P2Y12. The safest option with oral anticoagulant is clopidogrel. The BARC definition of bleeding is type 0 is no bleeding, type 1 is bleeding not actionable, type 3 is overt bleeding needing intervention or transfusion, type 4 is ABG related bleeding, and type 5 is fatal bleeding. So we always talk in terms of BARC bleeding in terms of ACS or in patients with CAD. Antiplatelet therapy and bleeding, the use of potent antiplatelet agents comes at a price. Bleeding risk is about 1 to 8% over 1 year. A pre-treatment strategy in ACS, it has been noted that STEMI, the pre-treatment, may be beneficial. In non-STEMI, it is better to avoid in case of early CAG. That is, if you're going to do an angio, not to load the patient, because it will unnecessarily increase if the patient has a triple vessel disease and goes for CABG. There will be unnecessary delay, and patient may have excess bleeding due to CABG. And certain patients like SCAD or Takotsubo cardiomyopathy or Minoka may not really need powerful agents like ticagrelor. So you can avoid using very powerful agents, and you may go with clopidogrel in these cases. So you have several short DAPT trials like the STOP DAPT, Smart Choice, Twilight trials, the Master DAPT, all of which have shown that even as short as 1 to 3 months of DAPT is non-inferior to 12 months of DAPT, especially in patients with high bleeding risk and stable CAD and stable ACS in very high ischemic risk. May extend the up to 3 months in even in patients with head bleeding risk. And the meta-analysis has shown second generation test short 1 to 3 months DAPT is similar in stent thrombosis, MI, stroke, and fewer bleeding events. So for secondary prevention, make a smart and balanced choice. Start with DAPT, shift early for high-risk patients, SAPT. So the take-home messages are statin as a mainstay of therapy for primary and secondary prevention, along with SAPT and DAPT. Clopidogrel is recommended as an alternative to aspirin in secondary prevention, as also in case of aspirin intolerance. Clopidogrel may be considered in preference to aspirin in patients with established ASCVD. DAPT is indicated for at least 1 year after ACS. Duration of antiplatelet therapy is based on ischemic versus bleeding risk, and long-term dual antiplatelet therapy not thrombotic benefit but increase in major bleeding events.